Hello, everyone. Hello. I'm Beanie Meadow. I am a neonatologist at the University of Michigan, but more relevantly for today, I'm Bill Meadow's daughter. And I am here to welcome you to the 5th annual Bill Meadow Bioethics Debate. This is an event that we've been putting on as the Meadow family, gratefully with the help of the McLean Center and the Department of Pediatrics here at the University of Chicago, in honor of my dad, who really likes debating people. So we thought it would be absolutely ridiculous to have someone come and do a lectureship when we could instead have 2 people with a 3rd person moderating them yell at each other. So that's definitely what we're going to see today. But I just want to thank you all for coming and for helping keep my dad's memory alive through this wonderful event. Today's topic, Too Many Toys in Medicine, Pros and Cons of the Latest Technology at the Neonatal Bedside, holds a lot of salience for me as I come into my role as the neonatology program director at the University of Michigan. I am starting a point of care ultrasound curriculum for my fellows, and I can just hear my dad in my head saying, why? What do you need that for? So I'm very excited to hear today about pros and cons of this and other new emerging technologies. But before we get to the actual debate, I first want to introduce our moderator, who holds really a special place in the Meadow family and in the Bill Meadow pantheon. Dr. Annie Janvier, a neonatologist, bioethicist, social media entrepreneur extraordinaire, who is one of, I would say, the most famous and most controversial acolytes of my dad. Annie is so well known in the neonatal world for her unbridled passion and advocacy for parents of NICU babies, as well as for neonatologists. And I think that her ability to really cut to the chase without any BS and speak so eloquently and so passionately about so many issues in neonatology is a real testament to who she is as a person, but things that I like to think that my dad helped to bring out in her own personality. So without further ado, Dr. Annie Janvier. Yeah, it's that one.
So thank you, everybody. It's a pleasure and an honor to be here. And if I can change the slides, oops. So Bill once told me that there's like every year more toys in the NICU. And why do we need all these toys? And we should go at the bedside. And some resident says, this shows XX result. And he's like, I know, look at the baby. So when I was asked to moderate, I thought of different topics. And this is Bill Hat. And Too Many Toys in the NICU is a weird title. So there'll be an official title after. But I wouldn't be where I am in my career, or probably my life, if I hadn't met Bill, if he hadn't given me 30 minutes to this weird, like, Quebec lost fellow at some point. Bill was unconventional, cut through the crap, did some real ethics of asking the real questions as opposed to some kind of weird theological questions that is hard to understand. He was extremely intelligent and multitasking in his head, always thinking about soccer a little bit, his kids a lot bit, and like 6 different things and going from one folder to the other. He was honest and challenging and extremely generous. He organized everybody's slides for them. And this is us several years ago when we used to be younger, being organized by Bill before a conference. And I'll use here, this is the Bill Meadow slide. You'll see Keith uses the Bill Meadow slide that needs to be black and white, and don't fuck around with blue and red and yellow, especially not blue with white on top. Like this would drive Bill's sick. Very minimalist, font more than 36 because Annie, there's so many oldies in the room that can't see anything. And max of 4 lines. And read the fucking slide. So this is one of the examples of a paper I wrote. So Bill was extremely, there was like half a sentence that was acceptable. So I had to work, he made me work so hard and drove me to the right place to honestly be able to say what I thought in ethics. So we'll speak today about technologies in the NICU. To improve neurological outcomes, we could have done cardiac outcomes. There's several respiratory outcomes, but we chose neurologic outcomes because I think that's what Bill would have preferred. Friend or foe, and I'm the moderator, and TERRIE, INDER, and Keith Barrington will debate. And we don't have financial disclosures. I mean, in ethics, there's no money, but I'm married to Keith Barrington, so it was a way to both of us come in Chicago together. No, it's because he's one of the good people to debate this. So TERRIE INDER will be pro-technology. TERRIE's one of the most amazing researchers in neonatology at the moment, and we're very lucky to have her here. She's dual trained in neonatology and child neurology. She's the director of the Center for Neonatal Research at CHOC, and her research focuses on the newborn brain to understand the timing mechanisms and impact of cerebral injury and altered cerebral development, and what can we do about it. Keith was trained in the UK. He's a professor of pediatrics at Universidad de Montréal and works at Saint-Justine. And he's done research, whether some randomized trials, animal research, and most lately QI investigations on how to improve the outcomes of neonate. And he's got the Shit Disturbing blog of neonatal research that questions the literature, questions what we're doing, what we should do, and Bill really liked that blog. So I'll have a little introduction, and then TERRIE will go, and Keith. They have 18 minutes each. I'm supposed to vigorously stop them when they've went past their time, and then we'll have a wrap up of 2 minutes each, and there'll be interaction with the audience at the end. So in the NICU, technology is necessary, and it has led to tremendous improvements. JF Kennedy had a baby at 35 weeks about 50 years ago who died. We rarely see 35-weekers die. So we were able to improve a lot of, improve survival and some of the morbidities in the NICU. But it has ethical implications that you'll hear about. When we have a new tool, is it research-oriented or is it clinical? Is there conflicts of interest, financial of who makes the tool, or personal or of who wants to publish about the tool? What is the evidence-based use about that? What's the distributive justice? Who gets that tool in the end and who actually can use it? And then there's evidence-based related to technology to improve neurological outcomes. Is it to understand the pathophysiology and develop interventions? Is it to improve clinical and long-term outcomes? Is it to predict the future and speak to families? And is more technology better, and how much evidence is enough? So I'll start with, so TERRIE, if you can come, and I'm starting my timer.
The dash is on. Thank you so much for the privilege of being here today and being here and the honor. And as I've said, standing both in the shadow and the shoulders of Bill Meadow, who I so greatly admired. I'm going to start really with the basics of what is technology. If you take the Greek origins of the word, it actually means art craft, and logos means word or speech. So we, however, take technology always to mean a device, right? Or a program that we humans use. I think, as has already been alluded, Bill, the legend, would have said there's too many toys in the NICU, but a toy is defined as an object for a child to play with. And you can argue whether neonatologists are children or not. Most of the time, I think we come close. Anyway, he also said, which I cling on to, never abandon your patients. So we're going to meet Jane. Jane's going to be part of our little presentation. She's a neonatologist here in Chicago. She's been here for 15 years. She works very hard to stay updated on the latest developments. She went to Hot Topics. She's an early adopter, and she loves new toys and technologies. So why does Jane or any NICU actually need technology for neurological outcomes at all? And I use these next two slides for myself to continue, what Bill had taught us, which is how can we, continue to challenge ourselves. This is data from 4 epochs of cohorts of very preterm infants, less than 1,500 grams in Victoria, Australia. It's statewide data, so it's valuable for that. And as you can see across these various epochs from the early 90s to the mid-2010s, survival has improved. Cerebral palsy has probably declined a little bit, particularly with cystic PVL going away, a form of brain injury. But this is a minor form of the disability that these infants face. The vast majority of these infants, and as you can see here, between 40 and 50% still across all of these time periods, suffer from neurodevelopmental disability. This is further reinforced by data from the United States, from the Neonatal Research Network, whereas you can see the same trends across 2 epochs in 2008 and 2013, that we, Houston, still have a problem, that nearly 50% of our very preterm infants in these later epochs are suffering from neurodevelopmental challenges at the time they are 2 years old. Let's look at something different. Let's look at brain injury. These are rates of intraventricular hemorrhage across a 5-year epoch from 2018 to 22. And sadly, the pale blue is the most recent epoch. And so as you can see, the rates of intraventricular hemorrhage or brain injury in our preterm population have not improved, and if anything, remain sadly high at over 25%. So Dr. Volpe and I, when we tried to renovate slightly the textbook, tried to put together a schema of trying to understand the pathway to that particular form of brain injury, the form of intraventricular hemorrhage. We tried to understand it in a ischemic reperfusion injury, where there was a risk with the maturity of either a major ischemic event or recurrent small ischemic events that injured the brain and made it vulnerable. And then unfortunately, we clinicians tend to come along with a hammer and lead to a lot of reperfusion opportunities, I'll call it, where we are reperfusing this injured brain, and that reperfusion injury then causes rupture of the germinal matrix. So if it's about cerebral blood flow, and seeing either if it's too low or if we're over-perfusing, couldn't we do a better job with a technology where we could actually monitor this? And so in comes near-infrared spectroscopy, which doesn't actually measure cerebral blood flow or cerebral perfusion. It actually measures oxygen saturation across the skin in the brain. So here's problem number 1. Is our technology really measuring what we need it to measure? But let's just say it's close, and we think saturation, cerebral oxygen saturation should be a crude measure of brain perfusion. If your levels fall very low and we want to avoid that, let's look at all the things we're doing to the baby and see if we can't help blood pressure if it's low, if we can't change the way we're ventilating the baby, if we can't check that we haven't got anemia that should be corrected. Are there things the technology can tell us to look at so that we can make decisions that would then improve the outcome? So this was put to the test, very large randomized controlled trial where this was rolled out with exactly what I've just showed you. Half the babies had it on, half the babies had it on blinded. We could see whether using that algorithm made a difference to brain injury. And as you can see here, under severe brain injury, it made absolutely no difference. So Jane was in that trial. She and her colleagues were using the machine, but was the machine really being monitored 24 hours a day? Did Jane or her colleagues know what to do with the information off the machine? In fact, less than 30% of the physicians who were undertaking the trial around the world were trained and completed the training module on how to use the machine. None of that, whether it was monitored, whether they did the right thing, was actually even recorded in the trial. So is the technology really a foe Or is it the NICU utility of the technology that is our foe? Technology really can't improve outcomes. What it can do is potentially be applied correctly, acted on correctly, informed correctly in terms of the way the family understand what's there, and then understood correctly what it has told you about future risk. Because all we're doing is taking a technology and saying 2 years later, did it improve outcomes? No surprise, it didn't. Here's another one. Let's put EEG monitoring on any baby we think might be at risk of seizures and see if they're having seizures and treat those seizures and make babies better. It makes sense. We don't want babies to have long, bad seizures. So let's do a trial. We'll randomize them, put them on the monitor, and then everybody will feel better. Well, actually, when you look at the trial that was done that did not show they got better, the babies in the monitored group had nearly twice as many seizures. How does that happen? Again, no one recorded what was happening with the monitor. Was anybody looking at the monitor? Did anybody know what to do with the data? Could they interpret the monitor? We were so worried about this paper when it came out that all of the people involved in EEG monitoring around the world got together and tried to write a commentary back about why monitor the neonatal brain with the EEG. Because fundamentally, clinically, we can't tell if a baby's having a seizure. We need this technology to help guide our treatment. Unfortunately, this trial just had many issues with it that we can't untangle. Let's go back to our IVH. What about if we don't know what's going on hemodynamically? We have a look at the heart and actually inform the care by echocardiography. Is that the right approach too to tell us what to do? Well, Patrick McNamara in one centre with expert users has done this. And he's been able to get an algorithm where he'll look with an echo at 12 to 18 hours of life and determine which pathway with the goal of protecting the brain. What has he shown? Not in a randomized controlled trial, but historical controls. He has shown in his centre with expert users applying this in the right way that he can significantly reduce the risk of brain injury, as you can see here, whether you're 22, 23 or 24 to 26 weeks. So in his hands, that can happen. But that doesn't mean, as you've already seen, it can be rolled out in any other place. Let's go to something simple, a stopwatch. So this very nice nursing bundle intervention that was designed to try and prevent IVH had simple things about how the baby should be positioned. Many places around the world do this. But the thing many people avoid looking at in this trial, and the thing the investigators think was most impactful, was this. They avoided rapid flushes or rapid withdrawals such that they had to be more than 30 seconds. And they applied this for at least 72 hours or longer. Now, why would that make a difference? And everybody had a stopwatch. Why would that make a difference? Well, here's our little preterm baby with their blood volume. Here's an adult with our blood volume. A standard draw after the baby's admitted is around 2.5 cc's. That's about 5% of a 500 grams blood volume. For you and I, that would be like the person drawing our blood takes 250 cc's off us, or us giving a blood donor pack in a minute. That's if we do it over 30 seconds, right? And this is in the setting of a poor preemie brain that has limited ability to compensate. And so myself, I thought, oh, of course I do 30 seconds, I'm slow and careful, but I'm not. The golden hour has taught me, get those lines in, get those labs off, get everything secure, get away from the baby. So I was way under 30 seconds in my draw and flush. And now with my little stopwatch, it keeps me honest. What impact did this intervention have on rates of IVH? A dramatic impact. Something very simple. What about MRI? Much bigger machine, much bigger cost. Why should we do this? And here were 2 infants I discharged in 1 week who were both born at 23 weeks gestation. Both of their parents were thrilled that their cranial ultrasounds had been unremarkable, or they had called them normal. And here were their 2 brains. Why would I want to use this kind of technology? Well, a lot of people say to me, we should wait to do an MRI until a child really has disability, because that's when you're going to really select the kids that might be informed. And in fact, Choosing Wisely said we shouldn't ever do it because fundamentally doing an MRI, although it does inform your risk of adverse outcome, not universally individually, but as a guide, it doesn't improve outcomes. Donna Ferrero came back and said no one was claiming that a scan can improve an outcome, but rather that performing a scan allows one to decide on necessary interventions that might improve outcomes. So in fact, an infant who's at high risk, which you've already seen, high risk for brain injury, should have, whether they have brain injury, at least documented when it's easy to do, when they're a little baby and they can be fed and wrapped and scanned, so that we can guide the risk for the family. Why is that important? Here's very important data from the HEAL study about what actually happens in real life. These are babies who were born between 24 and 27 weeks, and they were discharged into the community. And people say to me, well, don't worry, everybody's going to get early intervention. You don't have to worry about those babies. Look at this, in a trial setting, in a monitored way, even at a year, 50 to 60% of these babies had received any, didn't matter whether it was PT, OT, or speech, any type of therapy services. So they are not all getting it. We need to be able to assist families to know, because if we're going to use it, we have to apply it correctly, act on it correctly, inform correctly. So for the scanner, that means the right sequences, helping the baby lie still, informed interpretation in capitals. And when you do your MRI, if you want to do it in the NICU 8 weeks before they go home, you can start your NICU rehab right then. Their injury's already happened. Nowhere else in pediatric or adult medicine, if you had brain injury, would someone say, well, we're not going to look, we're not going to do anything, we're just going to wait, because we'll wait a few years and see how you go. So here is Stephen Miller's classification at 32 weeks. He uses it as a guide for whether it's motor only types of disability or motor and cognitive, to tailor the type of rehabilitative approach that you may also be looking for. We ourselves use a slightly broader way of assessing at term to look not just for injury, but broader types of impact on brain development, and developed a more complex score. But actually, once you train your radiologists, it's actually pretty straightforward. It takes them about a minute to give you scores. And this matters because when we send our babies home, this is the first slide here, they have disturbances in regional brain growth, but guess what? The same baby, this difference becomes more prominent as these children grow older. And interventions can be done at all stages, in the NICU, in early infancy, and in childhood. And interventions make a difference. So the studies are not as many or as well done as we would like, but at least there is data to support improvements in outcomes with early intervention programs. And I'm encouraged by the work that continues to come from elegant experiments like this from Vittorio Gallo, that look at the impact in a preterm model of hypoxia about enrichment in terms of motor, social, and novel objects for the rodent, that show that it has to be started early and it has to be continued right through development to have impact not just on function, but on regrowth and cellular function of the brain. If you do it just in the NICU or just after discharge or later in life, you don't see those benefits. So if we don't define this, we miss this opportunity. So technology is this combination of art and craft and word or speech. But the most important technology to me actually is the parents. When we look at our parents at the moment, the average presence recorded in the United States in a NICU is less than 2 hours a day. So 90% of the time our babies are alone. Average time of skin to skin, less than an hour per week. We know our babies are living in this crazy environment that, despite whatever room type you are in, is surrounded by various types of environmental experiences that are associated with adverse outcome. We don't want technology to do anything other than help us to modify those experiences, and certainly never to interrupt what we need most in our complementary presence of our families. So in summary, technology exists to be a tool to assist us. It's only as good as the device user interface. Application of the knowledge and a balanced humanistic utility are all needed. And I think Bill would say that all babies actually need toys. As Steve Jobs said, technology is nothing. What's important is that you have faith in people, that they're basically good and smart, and if you give them tools, they'll do wonderful things with them. So what does Jane do now? Jane was listening to all of this. She listened to this debate. She thinks learning more about technologies, probably a good idea. She's talking to radiology now about how to do better MRIs. If she's going to do one, she wants it done right. She's talking to neurology about EEG and when and how and what we should do. She's advocating for more therapists in her NICU to get rehabilitation underway. And she's going to buy stopwatches to look into technologies to better, and also to look into technologies to better track and document her parent presence and holding in her NICU, because this is something that's not available now. She's going to join the next clinical trial of technologies because she thinks it's an important way for her to have information that's going to guide her management. And I think that is where we are at. And I look forward to many important discussions.
Thank you very much, Terry. You can understand why I was a little concerned about having to follow Terry in this debate. She's someone that I have an enormous amount of respect for, all the amazing things she's done for babies, and as well as the fact that she's absolutely brilliant and speaks well. I'm not one for taking selfies normally. I'm glad I took this one. This was the last time I spent some time with Bill. And it was great to spend some time and to be reminded of his incredible intellect and of his sense of humor. I also want to start off with a confession, because the thing that attracted me to neonatology was technology. I remember probably about a century ago when I was a medical student, we didn't actually have, as part of the pediatric rotation, any visits to the neonatal ICU. It was too new. So we actually visited the neonatal ICU as part of our obstetric rotation. And I went into this NICU, and there was this tiny little baby hooked up to a ventilator. And next to it, there was this huge machine, which was some sort of mass spectrometer that was actually analyzing transcutaneous gases for some research that they were doing there. And I thought, wow, this is amazing. This is for me. This is what I want to do. So I actually decided to start this talk using the very latest technology. So this is ChatGPT. I asked ChatGPT to create for me a picture of a baby in an incubator surrounded by high-tech medical equipment. And I was fairly happy with this, except that I didn't understand what this wheelchair was doing there. So then I said to ChatGPT, get rid of the wheelchair. And it did get rid of the wheelchair, but it put another one in. So then I said, no, get rid of that wheelchair, really. It did, but it put another one in. I don't know why ChatGPT thinks that preterm babies and wheelchairs go together. I did eventually manage to get rid of all of the wheelchairs and get this picture of something that is that very horrible, sterile, cold, bright NICU that Terry was just talking about, the kind of things that we should probably in many ways try and avoid, with the noise and the bright lights and this hard, cold plastic, well, warm, but this hard plastic box that the baby's in. And as you can see, there's no human beings around this baby. And some of the technology is essential to good care. We need incubators to keep babies warm. We need oxygen mixers, which are very simple technology, but they're essential. We need cardiac monitors and other kind of monitors. But even that most basic equipment has adverse impacts. Even the most basic interventions, in fact, all of neonatology is a balance of benefits and harm. So even antibiotics, even when you need them, they have harmful effects on your microbiome. And if you don't need them, then they're just harmful. You need oxygen, but too much oxygen and too little oxygen, you need to find the balance. And humidity in that incubator can also have adverse effects. So I then asked ChatGPT to put a nurse in the room. And unfortunately, the nurse spends all her time looking at that monitor and not looking at the baby. Neonatals, we love knowing how to measure things. That was, as I say, that's what attracted me, this GC mass spec that's measuring transcutaneous CO2, because it was very hard to do in those days. And we react to those numbers when we get them. We like to have a CO2 that's normal, or maybe a little high is okay, but actually increasing the ventilation to bring the CO2 back down to normal, is that really a good thing to do? What harm does that respiratory acidosis do compared to the harm we do, permanent harm to the lungs of trying to normalize the CO2? And for neurologic monitoring, we can see some fascinating new numbers. And Terry's already talked about one thing that I'm going to talk about, the same study, maybe from a slightly different way, because I actually remember back when I was a fellow, again, a very long time ago, my colleague, Phil Etches, had actually worked with Peter Rolfe in Oxford, who invented near-infrared spectroscopy. Near-infrared spectroscopy, you can actually shine, the way that Phil Etches explained it to me is you can shine this near-infrared light through the brain and you can see what the baby's thinking. Obviously, you can't really see what the baby's thinking, but you can see how well their brain is oxygenated. And so, isn't that amazing? We can actually, and I've actually done some research here, that's one of my articles here, because you can non-invasively determine brain oxygenation. This must be great, because when it's abnormal, we can figure out why, and then we can change therapy to normalize brain oxygenation. That must be a good thing shortly. And this is, you've seen already what this looks like, a little probe that just stuck on the baby's head, and you actually get this this signal of the brain oxygenation here. And as you can see in this particular graph, showing how wonderful cerebral oximetry is, that as the blood pressure fell, the cerebral oxygen saturation fell as well, showing that the babies don't auto-regulate very well. So this study that Terry's already talked about is actually the third in a sequence of trials that this same group did. And what they did in this study, it's a very large study of extremely preterm babies, that what they did show was that babies in the NEARS group had less brain hypoxia. That they were actually because they followed all these or didn't always follow, as Terry has said, but many of them followed these fairly complex protocols, and they weren't actually able to show any benefit, despite the fact that they reduced the duration of brain hypoxia. Does that mean that brain hypoxia is unimportant? No, what I think it means is that many of the things that you're doing have risks. And when you're balancing those risks and the benefit, you actually come out with no benefit in the long run, because you're giving more transfusions in the group who had the NEARS. They were more likely sometimes to be started on anatropes, which have adverse effects. That among the various protocols, some of them had to increase the ventilation or increase the FiO2, increase the saturation limits. And those things probably all have adverse effects which balance any potential benefit from this. Does this mean we should never use near-infrared spectroscopy? I don't think so. I think there probably are times, and some centers now have lists of indications. This is actually a Scottish center that says these are where we're going to use near-infrared spectroscopy. But in fact, there's no evidence of benefit in any of those circumstances either. What we really need to do is to do more research and find out how we can actually get the potential benefits of normalizing brain oxygenation without these adverse effects. And it certainly is the case right now that there isn't a role for routine near-infrared spectroscopy in extreme preterm infants. How about EEGs? Well, actually, if we go back some years, it was actually very common in France, for example, to do routine EEGs in preterm babies. And they were looking for Rolandic sharp waves. They were looking for these sharp waves coming from the Rolandic gyrus in the central temporal region of the EEG. And they'd already shown previously that if you had these Rolandic sharp waves, you're more likely to have a poor outcome. So a lot of babies in France actually had their care redirected because they had Rolandic sharp waves. What we now know is that it's an extremely poor indicator, a very poor predictor of any kind of adverse outcome that actually matters to parents. So what people have done more recently, much more sophisticated analysis of the EEG background and looking for abnormal sharp-wave activity, looking for prolonged periods of quiescence on the EEG, looking for persistent delta brushes and other things, and then having a careful evaluation of longer-term outcomes. This is a study from the group in Cork. Another person I have an enormous amount of respect for, Jerry Boylan, is the main author of this. And what she showed was that if you do an EEG, and this isn't for continuous EEG monitoring, this is a prolonged EEG, but at a point in time at 35 weeks, that if your EEG was completely normal, the babies had a completely normal outcome. And if it was abnormal, then that only a third of the babies had a normal outcome. Well, and it's very highly statistically significant. But what did they mean by normal outcome? Can you really divide babies up into those that are normal and those that are abnormal? I don't know how many of us would consider ourselves to be normal or abnormal. The abnormal outcome here was defined as death, CP of any grade, or any one of the 3 subscales of the Bayley's version 3 being more than 1 standard deviation below the mean, which is about 20% of the population, according to that definition, are abnormal. And I don't think, and I think also one of the problems with a lot of this literature is that they've tried to dichotomize this richness of infant development into babies who are normal and babies who are abnormal. Almost all of the studies have tried to look at, is there a statistically significant difference in whatever they're measuring, the NIAS signal or the EEG or the MRI findings? Is there a statistically significant difference between the babies who fall into the good category and the babies who fall into the bad category? And in fact, the criteria for abnormality is different in every single one of those studies, just about. Most of the abnormal babies are defined as being abnormal in that bad group because of the results on the developmental screening tests, usually the Bayley's, but in other parts of the world, it's other screening tests, Griffiths or whatever. And it's usually at 18 to 24 months. And what I wonder is whether any of these modalities can predict outcomes usefully which are important to parents. Well, not all of the studies have looked at dichotomizing outcomes. Some of the studies looking at brain imaging have actually done this in a much better way. Marie Chevalier, one of my ex-fellows, and I, with Annie, wrote this article about these early head ultrasounds and how good early head ultrasound is, which is done as a routine in just about every NICU in the world, early sometimes being as late as a week of age. To try and figure out what the real relationship is between findings on early head ultrasound and longer term outcomes. But in fact, what you find when you look at that literature is that the most severe grade of hemorrhage are associated with a wide variety of outcomes. And especially when you're using very simplistic grading systems, which are used everywhere, such as the older Papille grading system, which was actually developed for CT scans and not for head ultrasounds. But children with grade 4 hemorrhages, some children with grade 4 hemorrhages are normal, and some of them are very profoundly affected because the terminology and the use of that term, a grade 4 hemorrhage, actually refers to a huge variety of different findings on head ultrasounds. And of course, term equivalent age imaging, or perhaps at 32 weeks, again, if you can do that in your center with MRI is another question. My big concern about all of these things is that a statistically significant correlation does not equate with clinical usefulness. Just because you can say that this finding on the MR is statistically significantly associated with a poorer outcome or with this kind of outcome, it doesn't mean that it's a clinically valuable thing to know that. All that significant means is that it's not likely to be due to chance. It doesn't mean that it's important, that it's useful, or that it should be routine. If you try and actually look at these things differently and sort of as a continuous variable, here you can see this is a fairly old thing. This is from another group, of which I have enormous respect, from the Hammersmith, from Dave Edwards and Francis Cowan, who actually looked, they were just starting to use the apparent diffusion coefficients, and they showed that the apparent diffusion coefficient here actually correlated and was statistically significantly associated with the GQ. This was a developmental quotient that they were using. And there, they showed that there's this statistically significant that the lower this coefficient is, the better the developmental quotient. But if you actually look at this in more detail, just say you've got one individual baby with a score of -50, that's associated with an enormous possible range of developmental outcomes. The conclusion of the study was that apparent diffusion coefficient values at terms may be of prognostic value for neurodevelopmental outcome in infants who are born preterm. My conclusion is that they're of no value for prognosis, because for an individual baby, any value of ADC can lead to almost any outcome, and statistically significant correlations do not equal clinical utility. So this is actually something that's performed in many NICUs, and if it's completely normal, the MRI at discharge of extremely preterm babies, there's actually a good chance the baby won't develop motor problems. There's a fairly high negative predictive value for motor. But in fact, those motor problems and the cerebral palsy is actually not as important to parents as you might think. This is from one of the, a slide from the Parents' Voices project, where they gave some clinical scenarios, these vignettes describing a child at 2 years of age. And one of the children actually had disabling cerebral palsy. It was a child who at 2 years of age couldn't walk, had stiff legs, and was predicted to actually be required this wheelchair that ChatGPT thought should be alongside with the preterm baby. And they actually asked the parents, so there's a very large sample, mostly parents, but others were involved as well, I believe, whether this was what the health status of this child with disabling cerebral palsy was, and they scored the child as 7 out of 10, whereas normal is 10 out of 10. And only 43% of the parents actually thought this was a severe health condition. Now, 43% is a lot, and it's obviously something that we want to avoid, but it's not necessarily something that we would equate to what parents think of that condition. So the uses of these neurological screening tools, I think that for research to improve outcomes, they're essential. But for the individual baby here, I've actually got really big concerns about it. I think that they have in the past, some of these investigations been used to determine the appropriateness of ongoing intensive care, but they're actually not adequately predictive of the importantly abnormal outcomes in almost any circumstance. That as Terry has mentioned, using these for follow-up, and yes, there's huge problems with getting adequate follow-up for babies. If you have very limited resources, you can use, I guess, your term equivalent MRI to decide which children you're really going to push for them to get follow-up and services. But in fact, the prevalence of these problems amongst preterm babies, I'm not being a Pollyanna here. I don't think all these babies do fine. A lot of these babies have big problems, and they should all be getting adequate follow-up and early intervention. Does the efficacy of the early intervention depend on the screening test result? I've not seen good data that shows that. I think it's probably important for all ex-preterm babies to get early intervention, regardless of the results of their neurological screening tests. And for counseling parents, well, perhaps a normal result might help to allay some fears in anxious parents, but you don't know until you've done the test whether it's going to be normal, and you risk causing anxiety in others, such as the finding that we had in our unit, a family who actually wrote an article that was published in Acta Pediatrica about what happened to them as a family when they found this cerebellar hemorrhage on the pre-discharge MRI for their little girl who's actually doing very well. So I think that these neurological monitoring toys, as we're calling them, are actually limited value for the individual baby and their families, that they should be used selectively when they might have an impact on clinical care, and that otherwise they should be considered to be research. Thank you. I did eventually manage to get ChatGPT to put a mother in. That ChatGPT thought that was skin care, but it was the best I could do. But I actually like the idea of having the mother inside the incubator with the baby.
Oh, you hadn't finished.
Yeah, that was fine.
Oh, shit. Okay. Okay, last round, I'll go back. So what are the future horizons, one after Keith and Terry have spoken? I liked what Terry was saying about like the place of parents, and we know that's good. We know that we can improve outcomes with skin to skin, but it's not done very much. So what's the place of clinicians versus technology? That's my question. It's kind of hard. It's hard, but it's way easier to buy an MRI machine in my center than it is to buy an OT every year, to have a human extra come in the NICU to help babies. Why is that so? And how should we evaluate and implement technology? So every year we have budget cuts in our institution. I'm sure that's true everywhere else. And they say, well, is this really useful? Is this really useful? We'll have to get rid of this. And more people are demanding more things, so that's more costly. So how do we evaluate technology that we use and that we should buy or that we should get rid of? Because NIR stays and they'll do research until they find a utility to it instead of just looking at something else. So what do we do? Should we start with Keith or Terry? We'll start with Terry, and I'll keep this there. And that's 2 minutes. That's hard.
Great question. So I clearly feel differently. I think that technology is an important component. And I think none of us now are going to be living without our cell phones or going back to periods where we didn't have AI alongside us. The question is, how do we interface the technology to use it in a way that is safe? Like babies need toys, they need enrichment, but we don't want them to have dangerous toys that could harm them. How do we ensure that the implementation of the technology causes no harm and could be of making benefit? And I agree, our individual prognostication and our individualized treatments are still in their infancy, literally.
No, I think you just gotta keep the mic close to your mouth as you're using it. There it is.
I think that the individualization of things is still in its infancy. But it doesn't mean we shouldn't be continuing to try. This one's got a light on, so hopefully this one will work. That doesn't mean we shouldn't be continuing to try. I do believe we have to be honest about where we are now, which is that we have not made any real progress in reducing adverse neurological outcomes. And despite whatever way we are training and doing things for clinicians, there's a gap, a significant gap in the way we are able to understand what is happening in the brain of our preterm infants. And if we don't look with technologies, we will never understand. Now, there is a huge problem in all trials, in my opinion, and I would love Keith's perspective on this. A trial can be beautifully done in an individual center with high utility found. You roll that out to a broader group, the whole thing falls apart. And this is the problem with, I think, the way the technologies have been rolled out, is that we have done a great job of maybe building a machine, but we haven't taken the user interface to the same quality of application of the technology to have the education and the knowledge to use the tool well. And that includes not just the clinician, but the ability of the clinician to translate that to the family. Because all we do if we bring more toys is scare more parents, because they see, why is my baby's heart being looked at? Why is my baby's brain being looked at? Why are all these things on? That immediately evokes concern. So there can be a very big detrimental effect if we are not prepared to explain and understand ourselves deeply what we are looking at, how it will make a difference, and why we should implement it. If we don't keep trying to cross this boundary, I fear we will remain stuck. And I think we need technology as a partner to be able to move forward.
It's I think I've got a light on it now. Yes. It's nice to be part of a debate where you actually agree with almost everything that the other person has said. And it's really a question of nuance. I think the differences between that are between us. That I think it's absolutely vital that we continue to look at how babies' brains develop and find ways of protecting and normalizing their brain development. Many of you will know that Annie and I have an extremely preterm daughter that we're very proud of, and that she's now starting her nursing training. But she had huge challenges in how she was learning, many of which I'm sure were impacted by the fact that she was born at 24 weeks gestation and lived the first weeks of her life in one of those plastic boxes. And in fact, we probably weren't there doing kangaroo care as much as we could or should have done. I think we didn't even really realize how important that sort of some of the things that happened during kangaroo care were. And I think that is where we really need to be putting our efforts. As I've said before, when you're trying to use these tests to individually predict outcome, all you can really say for any individual baby is that with this particular finding, your baby has a greater likelihood of being in this box than in that box. It's really just probabilities. And do those probabilities really help parents know how to parent? If we could even predict even more precisely, if we could get the newest sequences on MRI and hook that up with metagenomics and look at the intestinal microbiome, and we can say, yes, your baby's going to be in this box, should we really be doing that, or should we just be buying them some books?
So let me argue back. So I knew you were going to come to imaging. I just knew it. But so, the reality of imaging is it risk profiles. And I totally agree with everything about ultrasound and about MRI. And it makes me sad that we are not better informed to understand how to think about these tools. But I think it's no different to many other tests. When we take a test for a full blood count to look for anemia, we don't expect doing the test to improve an outcome. You have to take the test. You have to understand the child's diet. You have to decide whether you're going to give iron supplementation. If so, how much? You have to hope the child's also in a rich, beautiful family environment where they're going to get optimization of their environmental enrichment. All of those things are just as important as the test. And so when we do an MRI, for me, seeing abnormalities that were not even visible on other imaging modalities helps me risk profile. And if that baby is now moved up into a moderate or high risk profile, and particularly if this family is coming from a situation where there's enormous social disadvantage and the baby's exam is also not reassuring in terms of their clinical exam, then I am going to go at it to make sure there is a lot of protection around that family to make sure access to therapy services is ensured, because those are the babies that need us to fight for them, because they've got triple jeopardy, if you like. And that is what the technology is helping me. It's another piece. And I have to say, sadly, in the United States, there are 5 states that allow uniform early intervention services for preterm infants. There are many states who do not. You need to have documented brain injury on an imaging criteria to be able to get access. And so when the families have this, they've got the keys. They've got the keys to be able to unlock services for the rest of their child's time, up until school entry at least. So to me, even if I'm doing it for that reason alone, it's giving the ability for me to provide critical resources to a family who may otherwise not be able to advocate well for what is a critical time of brain development. You miss that window, it's very challenging. And so, that is where the technology to me helps. And if we don't look and help the families, and the way we communicate that, and the family understand that this is not me saying your IQ is going to be this and your risk of motor disability. This is me just saying you've moved up a little bit into a higher risk where we know being born early led to some changes in the way the brain is developed. That makes me know that, and I use the word rehabilitation. I don't use the word early intervention. I think it's a very unhelpful word. I think these babies, like any other time in life, need rehabilitation from the trauma and the injury they have been through. And we should just be advocating for it. And we sit back all the time and go, oh yeah, they'll get services. We don't even know. We don't even know if they're getting services. In studies with very good places, only 50% of them are getting anything in the first year of life. So they're not getting it. You can keep living in that la la land, or you can embrace the opportunity to go and fight for them. And I think Bill would want you to fight for them.
Thank you, Terry. I agree. I think I can tell you that even in the amazing healthcare system that we have in Quebec, it's still very hard to get services for these kids, and everything that we can do to make that to make that work for those kids is so important.
We fight for machines like nuts, but it's very hard to fight for people. Like, people will not be outside and have a big delegation of doctors saying, we need more OTs to do the rehabilitation in the NICU. But they'll scream and shout because Harvard has an MRI with this diffusion and Yale doesn't have yet the MRI with that diffusion. But they won't yell because they have one RT or one OT or one physiotherapist. So fighting for good people who are there, for parents to be able to be in the NICU, for parental leave in the US. For these things, parental leave is probably more important than your MRI. So why aren't, I don't know, a study of parental leave versus no parental leave in less than 28 weekers so that moms can be there? Maybe that's going to be much better. So we don't do these studies because it's not sexy, right?
I would argue totally and advocate strongly that parental leave is important. I would argue that our culture in the NICU is a significant barrier to parental presence. And it's not that the parents don't want to be present. And I was reinforced by a visit to Finland recently, where they have brought in a new form of collaboration with families. They had parental leave. Their families weren't present. They had the capacity, but the families were present because our culture is not in of what is the most important technology that exists. We have not, we still talk, you know, they're not visiting. This is their baby. You know, we're visiting, you know, but it's just to shift this culture is a major investment. It should.
Thanks so much. Can you hear me online, hopefully? Yeah, I just hear this discussion probably less in the debate, all in the context of EDM. So you brought up generalizability, and there's heterogeneity, average treatment effect. Often we forget about clinician expertise in involving evidence in practice. So I'm wondering if maybe in that spirit, one of the areas where you might disagree or maybe you agree is what level of evidence with respect to these technologies is required before we start incorporating them in care. You know, the trials are great. They're millions and millions of dollars. We can't do trials for every technology and every outcome. So we have to rely on lower levels of evidence. And, you know, I don't know if there's an agreement or how you each think about that.
Yeah, that's difficult, but I think, and I think it obviously, to me, it depends on what kind of intervention you're talking about. The things that Terry has just been talking about, sort of parental presence, we know there are centers that do that far better. If you go to Sweden, you'll find that most of the families are there most of the time. That in fact, that not just the mother, but the father and the siblings will all be there. The little kids will be running around. And the premature baby, even intubated, is integrated into care. I don't think you need an awful lot of evidence to be able to do that, unless you can, once you can prove that it's safe and the little ones aren't going to be bringing in germs in all the time, that normalizing the environment is something that I think you need much lower level of evidence for than the latest new piece of equipment. But I don't know how to say that more generally.
I mean, I think it comes down to what's the risk of harm, right? Can we cause harm? I think, for instance, when we rolled out at MRI, we really believed it was going to be beneficial. There was some data to suggest, at least from the UK group, that parent anxiety was at least lowered slightly compared to not having the MRI information. But that depends on who's communicating it. And that was in a unit where they were used to having MRI for a long time. They were used to talking about it. They were used to communicating. If you weren't that clinician and you didn't have a system in your unit and you send your babies down for an MRI scan and no one communicates effectively and sits with the family and truly communicates well, then we will do harm. And that's been beautifully shown by the McMaster Group too, and by the voices of parents. But, this is where, we have to take responsibility that when we roll a technology in, that we are well prepared with our user interface. And I don't think we've taken that responsibility. I think we love the toy and we want to be like everybody else. We want the toy, even if we don't know how to use it. And yeah. Right. And how can you roll an EEG monitor in and double the seizure incidence? I mean, something is wrong. I mean, the machine isn't causing seizures, right? I mean, it's like there's something wrong, right? So, people weren't educated about how to use the technology. So I think there are some very simple checklists that you can bring in. Do I think this technology is needed? EEG monitoring for seizures, in my opinion, is absolutely needed. It's important because you can't tell clinically if these babies are seizing. How are you going to roll that in? Who are you going to work with? Why do we in neonatology think we have to do everything ourselves all the time? Why don't we form collaborations and partnerships with other specialties who have actually got skin in the game and try and, form a sensible use? Then, take your time, get everything in place, and have parents come to express the way they think the technology should be rolled out too. Have the Parent Advisory Council in your unit have a voice about how this should be rolled out. And then, test it for a year. Ask yourselves, what's going to be my impact and how can I evaluate that? So that even when the trial is beneficial in an expert center, Patrick's trial was so great. Why are we not all doing, echo all the time and doing exactly what he's doing? Because I don't know whether that's, his historical controls. I don't know whether that would be the case if it got rolled out in a large number of units. So these are things that we have to ask and we have to do. Getting a stopwatch, drawing back and flushing slower, I think we could all do that, actually. Do we do it? I bet you we don't, right? Being able to monitor parent presence and holding, do we do that? No, we don't. Should we be doing that? I think we should. So yeah, there's low-hanging fruit, and as you go up the pyramid, you get to higher risk versus benefit ratio, and those are the ones where we should have a higher degree of input.
Yeah, I agree absolutely. I think we don't need a huge multi-center trial of stopwatches. I think it just makes so much sense, and it's cheap and harmless to do that. And when you get, and some of the things we do that we should be doing, like using maternal breast milk, the actual evidence for that is really not that good. But to be honest, who's going to not do that? Because it's clearly the right thing to do, even though we don't have that level of evidence to ensure that babies get maternal breast milk as much as possible. Other things, if you're starting to use a new molecule, then yes, you need that different level of evidence.
If you can't get therapists, can you help your parents understand how important they are as therapists? Do you have a reading program in your NICU? Do you have books available every day for the parents to have a new book to read to their baby? Are they reading to their baby? We just did in our unit, again, with the learner devices, the technology, what our auditory environment was. Our babies on average are hearing 17 minutes of human voice a day. 17 minutes a day. How many people are using technology to monitor their environments and actually capture that information? And guess what? This was in an open bay unit. You put them all in single family rooms, and guess what you're going to do? You're going to make it even quieter. And so how can you use technology to inform you, to help you guide what you need to do? And then as you're getting your extra therapists, use other ways of trying to educate your team about what can make a difference.
I took the first slide that you put up very differently. It looked like you had a dramatic increase in survival, and then conditional on survival, the rate of these brain injuries was constant. And you described frustration with that. And to me, if you develop technologies where you save more compromised and challenged infants, and you tell conditional and survival the problem's constant, you should be throwing yourself a party. And it seems to me, given the capacity constraints of some of the parents to provide the care needed, it's not clear to me intuitively that you can do a lot better than you've done.
So thank you for that really good question. So first component of it, yes, we have done well with improving and continue to keep pushing the boundary of survival. I would tell you the Vermont Oxford data that I showed on IVH has no difference in either the mean or the median gestational age or survival for that IVH data. So with IVH, we are not saving more small babies who are having more IVHs that's driving our IVH rate, which is actually kind of somewhat rising, because I think we have a lot of variation still in practice across the nation that is contributing potentially to some of that. But for the Australian data, for sure, we are definitely improving survival, but without an accompaniment of improvement in outcomes neurodevelopmentally. And I think we still have to challenge ourselves. If we can drop CP rate while improving survival, we can drop other neurodevelopmental challenges. Is 2 years and however many standard deviations you want to put on it the right outcome? Absolutely not. Which is why we're committed in our studies to try and push out, and we're just being funded by the NIH, hopefully today, to look at 25-year-old outcomes of the cohort of the data that I showed you, because we have to own that around a quarter to a half of our babies are still suffering brain injury that may be avoidable if we didn't do some of the current care paradigms we currently do. And in addition, brain development is significantly disturbed because of the experiences our babies are having. And that has a major impact lifelong on these kids, and particularly cognition, language, psychiatric illness, and sort of socialization. I'm just going to put it in a big bucket like that. And if we could, that doesn't mean because they face those challenges, they're not incredibly beautiful, amazing, strong people. They are. And what we have to say is, though, if something we are doing is disturbing development that could be avoided, then we should know that and we should do something differently, because most of these children would prefer perhaps not to face some of those challenges later in life. And I worry a lot about aging as well in terms of what we are setting our babies up for long term. So So shouldn't we be proud? Yes, we should be proud of what we've achieved. Are we somewhat stuck at the moment? I actually think we're kind of stuck without really viewing how we're going to really address the brain for the next decade in terms of both injury and thinking of injury as a separate thing, and each form of injury, IVH, white matter injury, cerebral, they're all different and their pathways are different. And brain development, which is independent of injury, right? And I think the biggest hope for me actually lies in this brain development paradigm. If we could get that right while we're still working on some technologies to help give windows into brain injury, it would be great. Does that make sense?
Just hold up for a second. It strikes me that you want to be really friends. You know, to increase survival and all of these kinds of additional offerings. But you're keeping them. No, you're not improving it, but it could be much worse. You could be saving babies who were increasing.
Right. Well, yeah, that's true. The less than 1500 grammars we have led to improved survival, and most of that is in 22 to 24 weekers, right? But those are a small number of babies, honestly, in the bigger scheme of things. When I break this data down, the group that still make me sad, and I can tell you if I could show you a slide, they're completely stuck. The 26 to 28 weekers as a group are pretty flat on survival. They're pretty flat on neurodevelopmental disabilities too, apart from CP, where we see some decline.
Yeah, I mean, I think that, when you contrast the pictures that ChatGPT came up with to where those babies should be, which is curled up in a very little space where all they hear is the murmurs of the mother's voice and the whoosh of her circulation, it's quite clear that the brain isn't going to develop normally unless we can do something to normalize that environment while we're going on. And I always tell my fellows that this baby here, this baby who's 32 weeks, is making 215,000 new neurons per minute. And that incredible, powerful brain development that's going on is so easy for us to disturb, and finding ways to protect that brain and to normalize and to allow a normal development with all those new neurons that are being created and tracking out to the cortex and spinning back into form all these layers of the cortex. This very active brain development is something that is bound to be affected, and we need to find ways of decreasing those impacts. So yes, we haven't made as many strides in some of those areas as others. And part of the problem, in fact, is also that we're not measuring some of the things that we need to measure very well. We've been measuring sort of developmental quotients, but we're not really measuring behavior and feeding and sleeping and a lot of other things that matter to parents as well. And again, I don't think a lot of those things are very normal either. And I don't think they're necessarily getting better either. But unless we start to measure them better, we'll never be able to find ways to improve those things either.
Yeah, I have seen some of the Swedish brains, and they're very pretty. And they are very pretty. They still have injury, but their developmental, their temporal lobes in particular are very good.
And in fact, if you actually look at the outcome data, you actually compare the outcome data from Japan, where they have a very good survival of these babies, but they're very interventionist, and there's a lot of noise and lights and dopamine and ultrasounds and all sorts of things going on. Their long-term outcomes are not nearly as good as they are from Sweden.
And, I would say, I was telling this story to Annie and Keith, but, I was on study section a couple of years ago, and there was a model where they wanted to approve for a preterm brain injury where it was a rodent model. They took the baby mouse away for 10 minutes a day and put it back. They also had some rough flooring. And, they felt, if they took the baby mouse away for longer, the baby mouse died. So this was sort of the maximum they could do for the model. And they asked me, there were 3 neuroscientists who reviewed it, and they asked me, is this a reasonable model? And I said, it's a good start. But I said, really, you need to take them away the whole time, put them in a plastic box, do painful procedures, have them under bright lights and noise for the entire time, and then you'd be closer. And this guy's jaw dropped open and he said, we'd never get animal ethics to do that. You know, I mean, it's just, it's sad, but true. You know, we lose perspective because we live in this world that we don't know anything different. Our babies are born into our world, but they wish they knew something different.
And one of the important things is we don't measure what's important to families. So the Voice of Parents project has shown us for BPD, parents, none of the parents we asked spoke about BPD. They don't care about BPD, but that's the only thing we do studies on. But they care about coughing during the night, coughing, not being able to go to school, rehospitalization. They care about 24 things we don't measure. So imagine if we measured function of the lung as opposed to our diagnosis that we invented and that we like. Maybe we'll actually find something, an intervention that will work in reducing hospitalization. For example, parental leave, not getting infected somewhere. And maybe if we measure function, so the F words, you know, for fun, fitness, family, all these things that are important to families. Families don't really care about diagnoses, they care about function. So if we can measure function, quality of life, all what the parents want us to measure, it's possible that some interventions will improve function without necessarily changing a diagnosis. So I think there's a lot of things that we're not measuring that matter, and that if we measured it, then maybe we could, you know, like feeding problems.
A very nice article was just published in the Archives of Diseases in Childhood looking at research priorities, and it was a research priorities kind of, you know, system that was used, and they surveyed a large number of neonatologists and a large number of parents, and they put out what were the top priorities. Out of the top 10, 9 of them were neurological outcomes related, either brain injury outcomes. There was one BPG. Parents care about the neurological outcomes of their children, and we need to listen to that and prioritize it. And amazingly, the parents and the neonatologists completely aligned on what they thought was important. And I think we need to hear that too.
Any questions online? So thank you for being here, and thank you for having us speak to you. We just spoke in 2 minutes extra.